Hello, Sports Medicine. We're on chapter 18, the knee, and this PowerPoint presentation is going to go rather quick. I'm not going to stop and show any of the videos. I want you to, after you see this portion, go through it and use the hot links to view the videos. They will support the 9 different injuries of the knee that the chapter covers. Upon the completion of the chapter, you'll be able to describe the functions of the knee, the ligamentous structures, the patellofemoral joint, and the 9 various sports-related injuries of the knee. It's the largest and probably most complex of the joints in the body. Most movements depend on it. So athletes, as they propel themselves forward, put a lot of forces through the knee region. There's a risk of overuse, traumatic injury, both contact, non-contact sports. All right, and so this slide has a little anatomical display. Is this a right or a left knee? I hope you said it was a right knee, based on the fact that the fibula should be on the lateral aspect. And here, as you're looking at the front of this knee, the fibula would be on the lateral aspect of a right knee. How can you tell? It's just by the location of the fibula. What are the 4 bones? Fibula, tibia, femur, and of course the sesamoid bone called the patella that's deep inside the extensor mechanism complex, here shown in that blue circle. Here's an x-ray of a left knee. The reason you know it's a left knee is because the patella is not there. And so if the patella showed up in the x-ray, you would assume that this is a right knee because the fibula would be on the lateral aspect. The fibula is actually anterior to the tibia, so you see most of the tibia, and you can only see a faint outline here of the fibula. That's because the fibula is anterior to the tibia. The illustration to the right shows the tibial plateau and the menisci. On the left-hand side here is the medial meniscus. It's a much larger footprint for medial stability than the C-shaped meniscus of the lateral meniscus. The ligamentous stability of the medial meniscus is a little bit greater than the lateral meniscus as a reference point for injuries. Most injuries do occur to the medial meniscus as opposed to the lateral meniscus because the lateral meniscus is a little bit more fluid and can move out of the way. The medial meniscus is also held in place by the medial collateral ligament, and then the illustration just below the menisci are the attachments of the ligaments, specifically here right in the center, the anterior cruciate ligament. So this is its anterior position, and you can kind of see this little V part of the tibia. That's the beginning of the tibial tuberosity, but that's again, this is a plateau topography image. The ligaments in the knee, as I mentioned, the anterior cruciate ligament starts distally, is an anterior medial placement, and it transcends posteriorly laterally. So that's your anterior cruciate ligament. The posterior cruciate ligament crosses it, and its attachments are opposite. And the attachment of the 2 ligaments make that X shape in the knee, hence the name cruciate, which stands for cross. Medial collateral ligament is a very vast ligamentous structure, opposed to the lateral collateral ligament, which is just that little small pencil-like structure y'all palpated in class when I pointed that out on a valgus stress test. The MCL is attached to the medial meniscus as well. So here's your meniscus on the tibial plateau. The patellofemoral joint or patellofemoral joint is the joint between the sesamoid bone, the patella and the archway of the distal end of the femur. And so the distal end of the femur has this large groove, and the patella has two facets underneath, a lateral facet and a medial facet, that ride on the bones as the knee flexes and extends. The pull of the quadriceps opposing the angle of the femur create what we call a Q angle, which is pretty close to the carrying angle in the elbow when we looked at the elbow. Patellofemoral problems, tracking and alignment can cause overuse injuries. Compression and traction forces can upset the articular surfaces. So most of the time you hear of a patella dislocation, which is our first injury, and the patella generally dislocates laterally. So if you take a look at the links on this slide, you're actually going to see a patellar dislocation and then a reduction of that dislocation. I think there's 3 or 4 of them that you can look at. Pain, giving way, crepitus, and swelling are all associated with articulation problems. The medial meniscus, or the patella, is held in place by the medial retinaculum, and it's also held in place by this lateral retinaculum. So when someone dislocates their patella, they've torn their medial retinaculum, and a surgical option is to go in and sever the lateral retinaculum to kind of offset that pull laterally to prevent future dislocation. So here they're opening it up, and then they're severing that lateral retinaculum to release the knee, to release the patella, so that it doesn't track laterally and dislocate. Second is meniscal tears. Again, medial meniscus is usually the one that gets trapped between the fibia and the femur and the tibia. The ligaments surrounding that ligament really just hold it in place. The lateral meniscus, though, can get injured and torn. Again, traction and compression forces are at work. So you've got mild swelling, knee pain, popping, locking, giving way. Treatment is compressive wrap for the swelling. Obviously crutches when their gait is altered, knee supports, activity modification, medications, and early motion therapy, non-weight bearing, like a stationary bike. So the meniscus itself, it's got pretty good blood flow to the rim of the meniscus, which is called the red zone of the meniscus. So both the medial and lateral meniscus have that good blood supply to the red zone. These tears in this red zone, those are the tears that get repaired. So a surgeon will go in, if it's torn here, they'll put in a suture, and that should heal. If the tear is in the white zone, they'll go in and remove the tear completely, because without the blood supply to the white zone, that repair will never heal. So that's the difference between a meniscal repair and a meniscectomy. Meniscectomy meaning they just remove a part of the meniscus, the part that's torn. Tendinopathy can happen in the patellar tendon, hamstrings, gastroc, popliteus. It's pain in the tendon, and so it's caused by repetitive high force strain. You're going to have tender to palpation at the tendinous junction, musculotendinous junction, or even up into the muscle in some instances. Activity modification, stretching, ice, bracing, and taping are all treatment plans for knee tendinopathy. So here we've got 3 illustrations of the muscles surrounding the knee, A, B, and C. In A, it's an anterior view. Basically, you've got the patellar tendon that you really need to worry about as far as tendinopathy is concerned. In B, if you find semitendinosis and semimembranosis, those are on the medial aspect of the hamstrings. And so that shows you the medial side, and then on the lateral side you'll have the long and short head of biceps femoris. And then down below the knee joint itself, you've got the lateral head of the gastrocnemius and the medial head of the gastrocnemius, which also can become, have that tendinopathy in those. And then illustration C, the gastrocnemius has been cut away, and you can actually see the soleus, which is deep to the gastrocnemius, as we learned in the ankle, foot, and lower leg. Fat pad syndrome, injury number 3. There's an infrapatellar fat pad. It helps with tracking of the patellar tendon in, again, flexion and extension. Symptoms include pain just below the patella, tenderness and swelling. So there's special considerations for fat pad syndrome, or a catching of the fat pad. And exercise, taping, icing, anti-inflammatory medications are useful treatment for fat pad syndrome. Medial collateral ligament sprains, medial collateral ligament strains are caused by a valgus force. In the illustration, you see the red arrow showing a force pushing on the lateral aspect of the knee, causing a tear in the MCL region. So that valgus force puts traction along the MCL, and that traction becomes too much and tears the tissue. Symptoms: limited motion, swelling, the medial aspect of the knee, certainly point tenderness and pain in that same region. If the valgus force is strong enough to completely tear the medial meniscus, the next restraint is that ACL ligament, which attaches anterior here to the tibia and then posterior to the femur. And so that valgus force can also tear the ACL as well. Torn anterior cruciate ligaments. Females are more susceptible. In the knee of a female, the notch between the condyles of the distal end of the femur is more narrow in females, and that's why they're more susceptible. In order to determine the amount of ACL injury, you would use the anterior drawer test. There's actually an instrument that can be attached to the knee called the ch18 that measures the amount of anterior displacement. So you can use the kt1000 on the uninvolved side and compare the involved side to see if there is some laxity present. Please watch the animation of the ACL video. This is a clear-cut case of PCL injury. The symptom is a sag test. So here you can see the tibia, instead of being in line with the knee, it actually sags way down, and so the femur, the head of the distal end of the femur, is way out in front of where a normal leg should be. So this is a positive sign that the posterior cruciate ligament has been torn. The posterior cruciate ligament stops the tibia from moving posteriorly. So without it, that is what you'll see, that posterior sag sign. We talked about epiphyseal plate injuries, the Salter-Harris types. They can happen here in the knee, in both the femur and the tibia. And again, if the growth plate is involved, this is going to disrupt growth. So skeletal immature athletes that have these injuries have to be very careful that they don't heal and close the growth plate early, leading to a leg length discrepancy. Osgood-Schlatters disease, group of symptoms involving the tibial tubercle. So it's that constant pull of the patellar tendon. The femur is constantly putting a traction force, and you can see that the bone starts to lay down more bone, and exostosis. So Osgood-Schlatters disease presents as a a bony nodule that sticks out of the proximal end of the tibial